put the time on the clock for a lecture, not a free paper. Go ahead, Thami.
So, syndesmotic lesions are often associated to ankle fractures and remain controversial regarding their diagnosis and treatment. Park and Mark Lorin say that the most important goal should be anatomic reduction and restoration of the syndesmotic and ankle mortise. And this is the only significant predictor of functional outcome. I would like to share with you our experience on surgical treatment and results after treatment of trimalleolar fractures associated with ankle syndesmotic injuries, and how worse is the prognosis in case of these associations. These fractures are the most potentially serious ankle fractures, chiefly when the syndesmosis is concerned. Along a series of patients treated for trimalleolar fractures and ankle syndesmotic lesions, 98 were available for clinical and radiological evaluation with an average age of 39.6 years and a follow-up of 13.5 years. The radiographic evaluation is useful for management of indications. However, the standard radiographic interpretation poorly assesses posterior fragment size because the fracture plane is usually oblique to this view. We used the DANIS and Weber AO classification, and we could find that we have type B and type C, which are involved in our series, with 59 cases, including 12 syndesmotic lesions, and in type C, 39 cases, all with syndesmotic lesions. The syndesmotic ligament injuries, the syndesmosis is made up for ligaments, and one knows that a rupture of these ligaments gives a 7 millimeter diastasis. This is the most common mechanism of this lesion. It's an abduction, as shown on this X-ray. Our treatment is regarding this trimalleolar fracture is either a posterior approach for lateral, then medial, with open reduction, internal fixation of the third malleolus by posterior or anterior screw. Fixing or not fixing the posterior fragment is based on its size. This is very classical issue. So the fixation of the posterior malleolus is made either by front or behind. And our technique of syndesmosis fixation is to use 1 or 2 positioning 3.5 millimeter screws, 3 centimeters above the ankle joint through the fibula into both cortices of tibia. Our aim is to maintain the correct position of the fibula in relation with the tibia. Additional sutures, when possible, or of ligaments, when possible, and of interosseous membrane are done when needed and feasible, which is not always the case. This is our method of syndesmosis fixation. Some equivalent of trimalleolar fractures are also treated by the same way with the syndesmosis screw. And sometimes also we have to add sutures on the deltoid ligament. We come to our results with the first group without syndesmotic lesions. We had 12 cases on 47 patients. That's 25% of this first group were symptomatic. In average, loss of flexion extension is 10 degrees, and late complications were 2 cases of instability and 4 of arthritis. In the second group, with syndesmotic lesions, we have 39% which are symptomatic, with mild pain, weather changes, and decreased ankle motion. In average, loss of flexion extension is 25 degrees, and our latest complications were 4 cases of instability and 7 of arthritis. The key to statistical tests remains slightly significant, since the p-value stands at 0.046, which is a little bit lower than 5%, but not very low. Some complications. This is just a moderate osteoarthritis, a more severe osteoarthritis when we have syndesmotic lesion on the trimalleolar fracture, a more severe osteoarthritis. Sometimes we have to treat a patient with arthrodesis, and these are our global results. The global results show that generally they are better if no syndesmotic injury. For instance, in the first group of 47 syndesmotic lesions, 72% are good and very good, while in the second group of 51 with syndesmotic lesions, only 51% have good and very good results. Could the syndesmosis be considered as a kind of virtual malleolus because of its apical topography? If yes, it's one more reason to reduce it and to fix it as well as possible. In the literature, significant correlations has been found between initial reduction of the syndesmosis and the late arthritis, the initial reduction of the syndesmosis and the late stability, the reduction of the lateral malleolus and of syndesmosis, and the late stability of the syndesmosis and the final outcome. So this is the ankle is a whole big issue, and one has to deal with every single item of this issue. An adequate reduction of the syndesmosis is necessary to achieve a stable ankle following B-type and C fractures. A slight shortening and rotatory malalignment are frequent and may lead to an alteration of the syndesmosis screw fixation, as said by Yablon. So since the syndesmotic injury aggravates the trimalleolar fractures and vice versa, a stable restoration of syndesmosis is always needed. And syndesmotic fixation lead us to precise our indication. Our indications are a combination with irreparable medial injury, high fibular fracture, a talar shift with fracture of the fibula, diastasis, while our contraindications of such screwing of the syndesmosis is found when if it is less than 3 centimeters of syndesmotic disruption above plafond, and if perfect reduction of the fibula and intact deltoid ligament are present. One of the last reviews made by in the literature, one of them is that of Amendola, who made a systematic review in 2006. And he said that therefore these complex injuries are associated with higher rates of complications. And it's obvious from the low level of evidence available in the literature of this topic that a great deal of work is needed before conclusive statements regarding the management of these injuries can be made with confidence. Conclusion: the trimalleolar ankle fractures remain significantly heavy lesions the syndesmotic injuries aggravate the trimalleolar fractures, and an early and accurate reduction and fixation avoid instability, avoid important range of motion loss, and avoid or delay arthritis changes. So we give you a rendezvous to next meeting next year, or whenever you have some time, go on to Morocco. Thank you.